Good evening, everybody. I'd like to welcome you all to Urology University. This is an ongoing learning and lecture series provided by Adult and Pediatric Urology. Today, our lecture is what are your options for low testosterone? When we talk a little bit about low testosterone, first of all, let's identify what testosterone is. In the past, it was thought that testosterone was just a sex hormone, but what we have come to know that testosterone has many biologic functions throughout the body. It does work with, in particular for metabolism, working with regulation of cholesterol, blood sugar levels. It works on the strengthening and maintaining of our bone strength as well as muscle mass. It helps with the cardiovascular system, the hematologic or the blood system, and lastly brain function. A reduction in testosterone is what we would call a male menopause, similar to a woman going through menopause with low estrogen. There's been a lot of terms coined for that, such as andropause, low T, etc., period. But what that can lead to is a reduced insulin sensitivity, causing diabetes or worsening diabetes. It can lead to impaired carbohydrate metabolism. It could lead to increased bone turnover, and that can cause bone weakness, resulting in fractures. Also, we worry about impaired cognitive function, mood, libido, energy, all of those things potentially changing with low testosterone as well. When we talk about low testosterone, we use the term hypogonadism. And again, it can be caused by several different things, but we talk about a primary cause and a secondary cause. The primary cause of low testosterone would be failure of the testicles to produce the hormone. And the second cause would be a lack of a signal coming from the brain area or the spine area to giving the testicles the signal to produce more or to maintain the level that the body should appropriately have. And that's called gonadotropin deficiency or secondary hypogonadism. There's been a lot of debate as to how many people actually have this out in the world, but there are several studies that have looked at the incidence, and one of the studies, hypogonadism in males, looked at the overall incidence, and what they thought was approximately 39% of men in the United States suffer from some form of hypogonadism. And of the people that present with signs and symptoms of hypogonadism, it's estimated that each of those will have 2 to 3 different presenting signs and symptoms. And a study back in 2000 showed that about 1 in 20 men who actually had hypogonadism were identified and then properly treated. So it is a misunderstood and sometimes a poorly diagnosed condition, and I'll get into the cause of that in a little bit. Why is it underdiagnosed? The reason that it's underdiagnosed is similar to erectile dysfunction. It's sometimes difficult for men to go into the doctor's office and express their concerns on change in libido, change in energy, lack of erections, lack of morning erections. Sometimes the symptoms are nonspecific. As I mentioned, mood, libido, energy changes, ability to concentrate are all kind of diminished from a cognitive standpoint with low testosterone. And a lot of times the primary doctor may look at depression or anxiety. One of those other issues is possibly the cause. Another reason is that for the same reason as a lot of these manifest similarly as like hypothyroidism, where the thyroid gland's not producing as much of its thyroid molecule, the signs and symptoms could be quite similar. Depression manifests as diminished energy, lack of libido, difficulty to concentrate. And then another difficult issue with the low testosterone is making the diagnosis. It does require a test of the testosterone level in your body, and we'll talk a little bit more about that. And then lastly, the reason that it's underdiagnosed is just general lack of awareness about the condition and the way it presents and the symptoms that men generally have with it. There's also a term called male metabolic syndrome. And what male metabolic syndrome is a condition where men have low testosterone, and they also suffer from diabetes, central obesity, hypertension, abnormalities with cholesterol levels. To make the diagnosis of male metabolic syndrome does require low testosterone as well as central obesity, and generally the waist circumference is 38 to 40 centimeters. We also worry about changes in triglycerides, which are generally high. HDL cholesterol is abnormally low, and elevated blood pressure, and then again some element of diabetes. A lot of people who do have low testosterone, as I mentioned, similar to male metabolic syndrome, will also present with one or more other conditions, and these conditions include obesity, diabetes, hypertension, hyperlipidemia, and asthma or COPD. The low testosterone actually can aggravate any one of these conditions and actually make the condition worse. So what are the presenting signs and symptoms of low testosterone? First of all, most people will present with kind of a change in libido. They'll also have a change in their erections. This could be lack of nightly or morning erections, inability to get or maintain an erection. We also worry about the lack of energy. A patient will complain of difficulty getting out of the bed in the morning, after a meal wanting to take a nap, whereas they haven't in the past. We also worry about different sort of mood disturbances, such as symptoms of irritability, depression, and then lastly we look at fatigue, lack of energy that I've already mentioned. Another problem is people at work will find that it's more difficult to concentrate on a task, get that task to completion as quickly as they used to be, used to presenting. So when we make the diagnosis of low testosterone, a lot of times we have our patients fill out a questionnaire called the ADAM questionnaire. And what that is a 10-question questionnaire that looks into the signs and symptoms of testosterone. If you have on the questions, question 1 or question 7 answered, that has a sensitivity of about 88%. However, the specificity of the condition is less. But if you have 2 or more of the other questions positive, and these include, do you have a decrease in libido? Do you have a lack of energy? Do you have a lack or a decrease in strength or endurance? Have you lost height? Have you noticed a decreased enjoyment of life? Are your erections less strong? Are you more prone to being sad or grumpy? Have you noticed a recent deterioration in your ability to play sports? Are you falling asleep after dinner? And then lastly, has there been a deterioration in your work performance? When we make the diagnosis of low testosterone, it does require an objective finding of low blood work. We do take a testosterone level. Total testosterone level of less than 300 is generally diagnostic of the condition. However, the testosterone can vary throughout the course of the day. In younger males from 20 years to 40 years, there is a peak in testosterone from about 6 to 8 in the morning, and that peak will go down slowly through the course of the day and will nadir down to a level, its lowest level at about 6 to 8 at night. As we get older, men in their 70s, 80s, and 90s, that variation or that change in level is not as severe. So it is important that when we want to make a diagnosis of low testosterone, that we do have 2 levels that are checked in the early morning hours, and both of those levels are generally less than 300. We also do some confirmatory testing to try to figure out if this is a primary or secondary form of hypogonadism. And the different tests that we do for that is we look at a prolactin level, FSH, which is follicle stimulating hormone, luteinizing hormone. Generally we'll check thyroid studies consisting of TSH or T4 level, as hypothyroidism can mimic or potentially cause low testosterone levels. Lastly, when we do make a diagnosis of low testosterone, it's at that point we would begin the discussion with the patient on how we would replace their testosterone. There are many different forms of testosterone replacement. These include transdermal gels. Of the transdermal gels, we talk about Androgel, Axiron, Fortesta, and Testim. We also have transdermal patches, which is called Androderm. We have buccal tablets. Now, buccal means cheek, so these are tablets that would go between the cheek and the gum and slowly dissolve, and that medication is called Striant. We have intramuscular testosterone injections, and that is called testosterone enanthate and cypionate. And then lastly, we have long-acting testosterone pellets that are inserted within the thigh, just under the skin, that last anywhere from 3 to 6 months, depending on how the body absorbs the medication. We're first going to talk a little bit about transdermal gels. The benefits of transdermal gels is it mimics more closely the body's own rhythm. And what I mean by that is it's applied in the morning and it gives you almost an instant peak of testosterone, and then during the course of the day the body uses the medication and the level is slowly diminished. And in the early morning hours before application, it does go back down to its lowest level. So the benefits is that it does reproduce what the body's most used to. The downfalls of the medication is a lot of times it's fairly expensive. It has incomplete insurance coverage through a lot of people's plans that can result in higher copays, deductibles, etc. And then the other issue is that a lot of people don't like a daily application. It does take time after the shower in the morning to apply the medication. It does require that the gel is completely dried. Once the gel or the alcohol within the gel is completely dried, then its ability to transfer from one person to another is diminished. One of the things we also worry about with the application of the gel is transferring it to a spouse, a grandchild, a child, etc. It can get absorbed and cause abnormalities within a child or a female, so that's something that we're very cautious and warn our patients about. It is possible that you can get skin irritation, and there are different places that the gel is applied depending on what's prescribed for you. It could be applied into the upper arms and chest. One of the medications, Axiron, is similar to an underarm deodorant that's applied after you place your deodorant in the morning. And another one is applied to the thighs. The next one we'll talk about is testosterone patch. This is a patch that's applied at night, usually around 10 o'clock at night, and it's kept on for about 20 hours. It reaches its peak generally in the morning, and then throughout the course of the day the levels slowly decline. The benefits of the patch is it's a single application. The downfalls of the medication, a lot of times there is some skin irritation that patients aren't happy about. There's also the possibility of just the patch coming off or weakening throughout the course of the day. The next medication is called Striant, which is a buccal testosterone tablet, and that's generally given twice a day. And it's a medication that goes in between your gum and cheek and just slowly gets absorbed. The reason it's not a pill that you can chew and eat like other pills is that it's a medication that needs to go straight into the bloodstream. If it gets ingested and digested and gets absorbed, then it can cause some problems within the liver, and the testosterone itself is broken down and does not deliver an adequate amount to the body. The downfalls of the pill within the cheek is that sometimes it falls out. It's hard to maintain there. But one nice thing is if it does work and you're happy with it, it's a good delivery system as well. Testosterone injections are what we call intramuscular depot injections. And the way that this works is the testosterone is bound to a lipid molecule, and this allows for slow absorption over the course of 1 to 2 weeks, depending on the amount of the medication that's given. There are some longer acting ones that can last up to 10 to 14 weeks. These medications are given either at the doctor's office or by the patient or a caregiver. It's a deep muscular injection, and what that means is you have to advance the needle through the skin into the muscle. We generally give the medication either once a week or once every 2 weeks. The benefits of the medication is that it generally is quite a bit cheaper for most people. It does offer a long-acting treatment that does not require a daily application. A lot of times it's generally cheaper for people who don't have insurance coverage or not able to get the medication. The downfalls of it is it does require a shot once a week or once every 2 weeks. And sometimes the muscular injections can be painful, or some people just have natural anxiety or apprehension to giving themselves a shot. We do check levels, and when we check levels of the medication, we do like to ensure that the level is checked at about the halfway point between the shots, because we know if you just have given yourself a shot, the level is going to be quite high in the beginning, and then just before you give yourself the shot, for the next cycle, it's going to be quite low. So we want to make sure that the treatment range in the middle of the week or the 2 weeks is with an acceptable level. And then the last testosterone replacement therapy that we have is testosterone pellets. Generally this is called Testapel, and what these are very tiny cylindrical pellets that get absorbed by the body over the course, as I mentioned earlier, about 3 months to 4 to sometimes 6 months. What the treatment requires is an office visit with a urologist. We clean the area around the thigh and infiltrate some local anesthetic called lidocaine or marcaine and make a small incision with the skin. A device is placed underneath the skin that allows the pellets to be placed in the position to where they will get dissolved over the course of time. The benefits of this medication is it only requires a treatment once every 3 to 4 months, or 3 to 4 times a year is all it requires coming in. The downfalls is that it is a procedure to place it, but most people have found that it's something that they're willing to go through because of the other options. When we do talk about testosterone replacement, it's also very important to have different things checked in the beginning before therapy. We always look at the complete blood count, lipid panel. We look at your blood pressure, and we also do a thorough history and physical exam. With the physical exam, it's very important to have your prostate checked on an ongoing basis. Testosterone itself cannot cause prostate cancer, but it can worsen a cancer that already pre-exists. So it's important to make sure that your provider checks a PSA level that's appropriate for your age range, and that also you have a digital rectal examination to ensure there's no irregularity, nodules within the prostate itself. As we monitor testosterone therapy, we look at a complete blood count, because testosterone can cause an elevation in the blood count. It can also cause changes in your lipid panel. So on a yearly basis, we do check a lipid panel, and we check a PSA level throughout the course of therapy. Generally, when I see a patient in the office, I will discuss with them, as I have today, the benefits of the different ways of treatment and the cons of it, and then let the patient make the decision. I monitor the testosterone level generally at about 6 weeks, where I check a complete blood count, a PSA, and a testosterone level. If it's stable at that time, then we'll move out to about 3 to 6 months. And if stable at that time, then we'll go on a yearly basis. The yearly blood work, again, would include a PSA as well as a complete blood count and a lipid panel testing as well as the testosterone level. It's important to remember, with all that being said, is there are a lot of signs and symptoms of testosterone that are confused. So if you do feel that you do have some of these signs or symptoms, you can go to the internet and look up the ADAM questionnaire, ADAM, and you can take that questionnaire to your primary care doctor or to your urologist, and then you can begin the discussion of treatment for low testosterone. I want to thank you very much for watching this today on Urology University.